ugly, really ugly. And that, I think, is why proximal protection is going to be the way to go with recently symptomatic patients, because we've got to be able to do as well as
separate
endocrinology or better.
angioplasty wire
I think
going
we
up
can
into
with
the
proximal
internal
protection.
carotid.
So do you want
challenging.
That's exactly what I was getting at. Thank you.
to do a little test here and show me where to put the balloon?
I think we know.
So Nick,
Show me a
based
picture
on
from before.
Can I see
that
picture?
comment you just made and the recent stroke guidelines about redefining TIA and stroke definitions, do you think this debate about TIAs not being important is over finally?
where
You
to
think
put
we
the
can
balloon?
finally get people to believe that if someone has a TIA, you
Can I see the
probably ought to
picture
do
from
something
before?
about it?
You have to know how the
the
diagnosis,
picture
how
of the
the
lesion,
definition
very
of
last
TIA
picture.
came about. It was Harold Adams sitting in a conference
little
about,
test there
I don't know,
just to show
15
me.
years ago, sitting in a conference with a bunch
Just
of
show me any
neurologists
picture.
scratching
Show me
their
the
heads,
very last
arguing
picture.
for a whole day on how to define TIA. And finally,
So
Harold
right
got
now,
up and said,
clip
Jesus
this.
Christ,
So
if
you're
we
good
don't
there. Let's
Okay,
go up.
so you want
make
to
a
go up on
decision
the
here,
balloon?
we're going to be here all day and all
Go
night.
up to
Somebody
10.
said, that's it, 24 hours, TIA.
Okay.
And that's how the definition came about. So it tells you how important that
Negative.
distinction is.
Squeeze your duct. Let me have
So
this
what
stent.
was the new revision, Michael?
No, I think the point I was trying to make is that there are lots of people who continue to say that TIAs aren't that big a deal.
Certainly not those having them.
So, Chris, it took us a little time to make sure we got this system in the place where we want it. But the thing we've done is all the equipment that we plan to use, we have it open. So it's just a matter of peeling back the layers. We have the pre-dilatation, post-dilatation, and the balloon and the stent.
What stent are you
already
using,
open.
Ty?
This
This
is
is
a
10 by 40
10 by 40 wall
wall
stent.
10 by 40 what?
Wall stent.
So again, chosen because of its deployment properties, because
So how
it's
do you-
closed cell, because it's easiest to use. Why
Do
do
you
you
like
Yes.
that position?
Probably all of the above.
Is that position okay for you?
Yeah, you're fine. You have the pulse.
Yeah, there you go. You see the live fluoro here, Chris?
Nice, Steve.
Good.
That's a
good.
small artery.
Yeah, we measured it. We chose an 8 by 40, although the common was maybe a little closer to 6, 6.5. And so now do you want to do a
So you
post-fill
have the
balloon?
clock running for his ischemic time?
Well, she doesn't seem very ischemic. She's squeezing her duct and talking.
Come on, let's go.
I'm ready. So do you want to
did-
post-deal
let's go.
this?
Yeah.
Did the patient squeeze the duct, or was that the nurse?
Yes, it was. And she also wanted me to correct, it's her birthday today, and she's 65, not 64, as I told you before. So this is the post-dill balloon.
So Ty, you're still doing passive aspiration, just the blood pressures?
I think I'm just getting in Steve's way, but yeah, I'm doing
Every-
every time we
Every maneuver.
make a maneuver where we cross that area, even though we have it stented now, I do active aspiration
Okay.
as much
You
as
wanna go
possible.
up right
But you know, when
there?
the TUI is open, there's the risk of getting air. So it's sort
Squeeze
of
your
a
duct.
combination
Negative.
of working
Negative.
with Steve.
What size balloon?
So it's a 5 by 2, and every time we inflate the balloon, you can see on the image that she coughs. So do you want to stop there
Yep.
and take a picture?
I'm going to take these down. So go ahead and deflate now.
And she also felt that when we went up. Okay, so
Let me go ahead and deflate this, Steve.
And is her blood pressure stable and
her
heart
blood
rate
pressure is
stable?
fine. Heart rate, 100.
Okay. I just want to give her a little breather.
Okay.
So did I miss that post-inflation? Did that happen?
Yeah, we did the
Man.
post-deal.
Reminds me of my first honeymoon. That was quick.
Yeah,
So you take the ECA out.
a lot quick.
Take the ECA out.
Take it down.
Yep.
Suck negative.
That's not negative on it already.
Give me a
so it should
20.
be
So
okay.
Ty, you're actively aspirating now?
I'm active aspirate. Steve's going to pull the ECA balloon out. You know, so this is outside of the stent now. So he's just going to watch this and make sure that it comes out easily.
So
this So we're balloon is pulling that actually behind the outside of the
stent. It's been stented, against the wall, but it pulls out pretty easily. So that concern about
So I think
trapping
we can
the
take
stent
our
or
first
trapping the
result.
balloon with the
Let the
stent
balloon
really isn't an issue. So that external balloon was trapped?
behind the
It's
strut?
trapped behind the stent, so you really just have to make sure. It takes a little time for it to deflate, so just make sure that it's adequately.
Has that ever been a problem for anybody? Nick?
Supposedly it's been a problem, but
Trapping the external balloon behind the stent in the common carotid?
yeah, there are a couple of different tricks. One is
Okay, so
they
that
recommend
balloon-
just loading a balloon
People
over
have
it.
had problems with it. It hasn't happened to
Okay.
us yet.
You ready?
Yeah, take that wire.
Take this one out?
Yeah.
Okay, you want to bleed these really good?
Yep.
And make sure we have no air.
It's pretty low profile, and it's not likely to get stuck. But
Okay.
Kind of self-expanding stent, I
Right.
would
Let
think
it come
that
back
wouldn't be a
towards yourself.
problem.
Let it bleed back into there.
Just go. Let's do this.
So are you still having flow reversal?
No, we're finished. We got all the wires out. We have flow reversal turned off. We're just bleeding the system. Making sure we have no air.
Did you say this
Both
was a
ports.
restenosis lesion or
This
de
was a
novo?
carotid endarterectomy in 10 of '08, and she restenosed it immediately thereafter.
So that's another
We'll
predictor
test.
for bad outcome is early failure of the endarterectomy.
Okay, ready?
10:08, so that's 6 months.
And then we'll take a
It's a
DSA.
predictor for bad outcome for what?
Okay.
For stenting or for?
So,
I think it predicts
DSA.
Yeah, I think we can stop there. That basically demonstrates the case. And so what you saw earlier this morning was the MoMA device, which is the other proximal protection device. So this is the Gore flow reversal device. And one of the differences is that with the MoMA device, the balloon is fixed. With this device, the balloon actually goes in through a separate port. So it gives you a little bit more, I think, flexibility as far as being able to get into some of these very tight or subtotally occluded external carotid arteries. The advantages of flow reversal are that if you do transcutaneous or transcranial Doppler, you don't get any hits, and that's what the literature has shown, so far. Now that may translate to not having any debris. We see on MR, we see these subclinical strokes in patients with and without embolic protection device. There are still what we call hits with transcranial Doppler when we use distal protection devices. But to date, with the proximal protection devices, you don't get the hits. Whether those hits translate to some of the presenile dementias that we see, because intuitively, and all of us, I started my career doing carotid stenting without distal embolic protection. And so all of us, I'm sure, have done that, and we're very comfortable with the filter. So this is a new technology. It requires a little bit of different type of a learning curve for us to be able to master it. But I think if we have a technology that allows us to do this procedure without any embolic debris at all going to the brain, then certainly that has to be better than just a little bit of embolic debris. And so in the future, if this bears out with, I guess, with larger series or with randomized trials, if that ever comes to fruition, then I would expect, or I would anticipate, and you can quote me on this, that in the future, most carotid stenting would be done with proximal protection as opposed to distal embolic protection.
I'm sorry for the interruption, Mr. Chairman. We have totally run out of time for this particular presentation, but we can take up one question and observation from the chair, and then we'll move on.
Excuse me,
Okay,
Dr.
yeah,
Fowler.
Dr. Kent.
I missed the beginning of presentation. Did this patient had endarterectomy before?
The patient had an endarterectomy before, yes.
Okay, thanks.
I think we have done. Move on to the next one.
Tyrone, just a point, an important point. It's a beautiful technique, maybe better than MoMA, because that's a true reversal flow. But how you could explain that is the last study published, reported by Nick Hopkins, the complication rate is the same as with any filters, 3%.
Yeah, that's why I said I think there's the whole issue with the carotid stenting in general, the learning curve. So I think there are complications with the procedures. This one seemed a little more cumbersome in the beginning. I've done both MoMA and the Gore device. I find them equally easy now. Early on, they both were challenging because I was more comfortable with using the filter device.
Yes, it's not a device for beginner.
It's not the device for a beginner. I think if the beginners learn all of the, if the beginner is someone who's being mentored and learns this technique, in an organized fashion, then that's probably the device of the future. But it's certainly not something that you can just go